and colleagues from Agra. I start with thanks to the Agra Orthopedic Society, particularly for the last few weeks, and my special thanks to Make Money and Kaushik Dasgupta and his team, who's helped us to come together today. You have heard Professor Javed. He really is one of the most dynamic experts in the field of osteoporosis globally. And it's a pity that he couldn't come in person. He was very keen to. I am not an osteoporosis expert anywhere near of that level, and I'm kind of deal with osteoporosis more by accident than by design. And it happened about 12 years ago when my senior colleague in the department retired, and I ended up with the osteoporosis service. And for me, it's been a journey. When I started, I thought, what is there in osteoporosis? You have 2 or 3 drugs at the time, and basically just use it as you would. But the more depth you get into the subject, you realize complex areas. And to be perfectly honest, the guidelines that are prolific, every country has guidelines, every society, especially society, has guidelines around osteoporosis. They do not do justice to some of the patients we see in clinics. So I pivoted out of inflammatory arthropathies into osteoporosis about 10 years ago, and it's really been a journey for me, and I'm still learning. So bear with me while I share some of my experiences, more as a fellow traveler. You see some of the consequences of osteoporosis. In rheumatology, we create a lot of osteoporosis because of the drugs we use, not least steroids. And ultimately, we have to work together. The situation in India is osteoporosis is not really very high on the agenda of the rheumatology community, sadly. We are so involved and so obsessed with complex connective tissue diseases and biologics. Osteoporosis is slightly not given the respect it is due. And I'm very grateful to people like yourselves who have spared your evening to come to have a discussion, because it is important. As you heard from Professor Javed, the demographic profile of India is changing very rapidly, and I say this in jest to my orthopedic colleagues, I work in a fairly big university hospital, and we have, last time I counted, 38 orthopedic surgeons, and there's only 7 rheumatologists. It is a major trauma center, and in their defense, there's a lot of work. But I say to them, they've been steadfastly rather reluctant to engage with us to develop a fracture liaison service. And I say that, are you protecting your own interests by allowing these fractures to happen? And, but it is in jest, but it is also a serious thing, Here, the situation is slightly different, and we work, but there's no reason why you cannot have a fracture liaison service in an NHS hospital. Anyway, I digress, and I'm conscious the time is running out. So there it is, to some practical lessons from the osteoporosis. Okay, next slide, please. So these are my affiliations. So I do not have any specific conflicts of interest, except that Kaushik Dasgupta and Make Money have been facilitating travel to come here, and my thanks to them. So I'll start with a quick, so to succeed in life you need 3 things: a wishbone, so you need to have an ambition, a backbone, metaphorically and physically, and a funny bone or a sense of humor. And you can see this is what osteoporosis looks under a microscope, and it is not hard to imagine why bones fracture. And one of the key things that I've learned in my last 10 years is there's a wide range of clinicians who look after osteoporosis, and that is one of its strengths because a lot of different people can actually intervene, except that they don't. So it becomes a kind of orphan, you know. The gerontologists see a lot of the fragility fractures, and we have orthogeriatricians in our hospital. The orthopedic surgeons like yourselves, we fix the fractures. And then there is a wide range of other medical specialists, the endocrinologists, the rheumatologists, who run osteoporosis clinics. In India, from the physician side, it's mainly the endocrinologists who delve and deal with osteoporosis. And although we have medications that work, and you've heard a bit about some of them, the emphasis is on pharmacotherapy and improving BMDs. The emphasis should really be on reducing fragility fractures, of which pharmacotherapy is one element. And we tend to forget that because the other things, like treating sarcopenia, like treating false risk, are not that easy. It is much easier to give a pill or an injection and then forget all about it. So I think our focus needs to be slightly broader when it comes to osteoporosis. And I have found out, you know, the art of medicine exists more in osteoporosis than some of my other areas of interest. And it is really, we have networks in the Midlands where I work. We meet every 2 months and we discuss our difficult cases. So I would recommend the network model where we discuss our difficult cases, and at the end of it, people scratch their heads and say, well, you know, I'm just glad it's not my patient and it's yours. So it's rarely black and white, the more difficult patients. But the vast majority of osteoporosis should be treated in primary care. It's fairly straightforward. And there's the tip of the iceberg where you have difficult patients, and those are mainly related to people with chronic kidney disease, on aromatics inhibitors, and all kinds of various things that are coming. And the longer that people are living, with longevity comes a lot of comorbidities, and osteoporosis is one. And it has a huge impact on quality of life and mortality. So we'll start with some questions just to see if you are too tired and you're paying attention. So my first question is, and those of you who have the app or can respond, or you can, there's not that many, you can raise your hands. So osteoporosis treatment in a patient with a fragility fracture, whose responsibility is it? Because this is vitally important. Is it the patient's primary care physician? Is it the physician, like myself, who specializes in bone health? Or the orthopedic surgeon? You can have your answers now if you are.
You can give answer.
I would say 3, but I'm not.
Yeah. Or while the technology is working, just raise your hands who thinks it's 1. 1, primary care doctor.
Ideally, it should be 1.
Okay.
Second.
Right. So there are no right or wrong answers to this. This is a matter of.
It has to be 1. But if it has, as an orthopedic surgeon, if the patient has no history of previous treatment, and whenever I see that patient, it's my duty to do that.
Correct. So ideally, most of osteoporosis, and not necessarily the ones with fragility fractures, should be the responsibility of the primary care physician. In the UK, they're very good at dealing with COPD, diabetes, hypertension, hyperlipidemia. But when it comes to bone health, it's a big black hole. And there are many reasons for this, which we won't go into. One of which is the lack of confidence and knowledge. And the focus is on all these chronic diseases, but not bone health. And that is a recurrent theme you will come across, is bone health is neglected. Okay, so the vast majority, this is another.
This is the first question.
Okay, first question.
No,
Okay. I don't think D was an option. So many of you feel it should be the specialist physician. Well, there are not enough specialist physicians with an interest in bone health, not even in the UK, who can deal with the volume of case. So I think that probably a more pragmatic way would be, as you have said, sir, is stratification. The vast majority of people with osteoporosis and fragility fractures can be dealt at the point either when they go back from the fracture clinic or discharge, ideally by the people who are seeing them in the hospital, or with a clear instruction of the primary care to follow it up. And that is where fracture liaison services come in. Okay, so we'll go on to the next question. I'm conscious of time. If you were to start treatment in a patient with fragility fracture, what would be your approach? You would do a clinical assessment of fracture risk on its own, and you say, well, this is the patient, this is the history, you had a fall from a standing height, or maybe not at all, if it's a vertebral fracture. You do a clinical assessment plus some sort of fracture prediction tool as a routine process, or you would wait for a bone density scan before making any decisions on whether to treat the patient.
That the patient has a fragility fracture in itself.
Okay? And that is the message. If you've had a fragility fracture, it trumps everything else. But sometimes in younger patients, we are not quite sure, the definition of a fragility fracture. I don't need to tell an orthopedic audience, but there are some queries, and you really want, and then also there is a question of patient choice. There is so much misinformation around these drugs that they'll say, well, actually, you might want me to have this drug, but I won't. So using a fracture prediction tool sometimes gives both the physician and the patient a framework on which to base the decisions, because you can never be certain that that patient A will benefit from the drug, and that brings us to the question, the perception of benefit. So if they had a fragility fracture and they're having back pain, and also they have concomitant degenerative spinal disease, they'll say, you've given me the drug, so those are ramifications of this process. We tend to use the FRAX tool quite routinely just to base our decision. Should we be challenged or should there be a problem? Then we can say that this was why we treated the drug. It wasn't a subjective decision of mine alone. And in an increasingly litigious society, I think those are helpful, but also in a clinical sense.
Exactly.
But going back to what Dr. Jha said, is if someone has a fragility fracture and is of a certain age, that is osteoporosis for all practical purposes, and you put our new in treatment. Okay, so the majority of you would. So hands up who use FRAX or any other standard fracture tool in daily clinical practice, right? And use FRAX India, because there is a difference, and it's an interesting concept. So I'll show you a patient who's of Indian origin. She came, first generation Indian, residing in the UK like myself. It takes about 2 generations for their fracture risk to change, and we use FRAX India or Pakistan or Sri Lanka, depending on their origin, and 33 different nationalities for them. The difference is that the FRAX UK has a variable intervention threshold, which a lot of the other countries know. There's not enough data. I don't want to go into the nitty-gritty of FRAX, but if you can use the FRAX India tool, it will help you make some decisions. And the intervention thresholds are, for the Indian FRAX, is 10% for major osteoporotic fracture, 10-year fracture risk, and 3% for hip fracture risk, which is different to the UK. So the UK varies with age, and the US is 20% and 5% for hip fixed. So the Caucasian patient's fracture risk and the Indian patient's fracture risk, based on the same epidemiological data, is not the same. So it makes sense, if you did use FRAX, to use the Indian version of FRAX.
Third question. Your third question. You don't use this one.
Okay, third question. What is the optimum time to start osteoporosis treatment after fragility fracture? As soon as possible. Brilliant. Because there have been concerns within our osteoporosis community, oh, if I give zoledronic acid after a hip fracture, it might interfere with, fracture healing and all the rest of it. The answer is it doesn't. And using any intervention, although we have heard from Cassie that ideally you should use an anabolic drug, that in practice is not often the case for a variety of reasons, not least here for cost. How many patients can afford even 3 months of homocysteine? But we should start, if we feel that patient needs treatment for osteoporosis after rigidity fracture, irrespective of what we want to use, we should start at the time. If we didn't, it's a missed opportunity.
Don't you think if there has been a surgical intervention, let the wound heal and then initiate?
Yeah, that has been the standard practice that we have been following.
When you say wound healing, you mean the skin?
Surgical, yes.
Yeah. I don't think. The problem we have in the UK is once these elderly people go home, then in some ways, without a defined fracture liaison service, which is not all pervasive, you do not have access to the patient again. You might think in a country like the UK that shouldn't be a problem, but it is. And they get left out. So we now have a hip fracture pathway in our hospital, which I have started, is we give them Ibizol before they're sent home with front-loading vitamin D. We don't wait for vitamin D levels because that will take time, and there's a rush to send them out because beds are short, and we don't wait for VNDs. Unless there are convincing reasons for not giving Ibizol, we give them, and then there's a range of opaque options, whether you give 3 every year, whether you give every 18 months. We now have data from New Zealand which one Ibizol can last for 5 years. So, okay. So yes, if that is your practice, I don't see any reason why not to. But what I suppose you've all said is you don't wait for the fracture to heal before starting any treatment for osteoporosis, because these are anti-resorptive and they may, the conception of they might impair healing is not really the case. Shall we go on?
Next question.
So, how long should they stay on treatment then? So let us say you've started someone, they refused IV zoledronic acid, they can't afford an anabolic drug, and you started on a generic oral bisphosphonate, could be alendronic acid or risedronate, which is I prefer for my more slightly older patients. So 6 to 12 months agreed. 12 to 24 months, a third of you feel that you do. And it could extend to several years. So if anyone is brave enough to defend option B, I'd like to hear it.
No, I would say lifelong.
Well, there is a view.
Osteoporosis is
It's a never-ending process.
Right. Now that is a debate that rages on in the osteoporosis world. How long is long enough? And that brings us to whether you give drug pauses or used to be called drug holidays. The proponents of lifelong therapy say no one actually questions lifelong therapy with a statin or antihypertensive drugs or drugs for asthma and so on. Why are you so obsessed with not giving long-term osteoporosis drugs? And I think it boils down to several factors. One is, if you have the choice of any osteoporosis drug you want, the best drugs are time limited. So you cannot give romosozumab for more than a year, and we've heard today it could be 3 months. There is still concerns about the problems with either abaloparatide or teriparatide beyond 18 months or 24 months because of all these risks which haven't been proven of osteosarcoma. So at some point you will have to switch to an anti-resorptive as the science stands now. And the question then is which anti-resorptive? Ideally denosumab, but and less so with drugs like oral bisphosphonates or ibizole all have their pros and cons. The one thing that, if you take home one message, denosumab is a drug that is actually lifelong, which is why we are very, very careful in starting denosumab in younger patients.
And we should be more careful on stopping it.
Right. So I will come to that, because there is a school of thought, or school of practice, I should say, that you give 3 months of teriparatide, give a couple of denosumab injections, and then that's it. That is not an unreasonable way of improving bone quality in the short term, but there is a huge risk after 2 or 3 injections of denosumab that there will be a reversal of the benefits, and in fact they can go down below the baseline and incur more fractures. And if you really wanted to stop denosumab, you have to follow it up with some other anti-disruptive treatment like ibizole.
Alendronate.
Or you could take alendronate, at least alendronic acid needs an acid environment to be optimally absorbed. And if you're taking a PPI, there goes your efficacy. No drug, no efficacy. And then they won't tell you. I have patients who are dutifully prescribed alendronic acid by their GP, and it's stacking up in a drawer in their home. They just don't like taking it. I have gone off weekly alendronic acid, and for people who don't have renal problems, I've become increasingly fond of zolendronic acid, but with increasing intervals between them.
Can I ask
How
you a
many
question
years do you
between-
give for
because
the oral?
You are a physician, so
Correct.
can I ask you a question between alendronate once a week vis-a-vis alendronate once a year? What is your take?
Okay, so all bisphosphonates, with the assumption that they are being taken regularly, that is a given, because alendronic once a week for a year, you're not quite sure. But let us say you have a patient who is really compliant and is using it properly versus IV zolendronic acid. Zolendronic acid is better. All bisphosphonates, zolendronic acid after 3 years, alendronic and risedronic acid after 5 years, they go up and then they plateau, right? So there is no incremental change in bone density after about 5 years for oral bisphosphonate, 3 years for Zol. On the contrary, with denosumab, the rate of improvement of BMD slows down, but it's still there is incremental change as you go along for 10 years, 15 years, 20 years.
How long can you give denosumab?
Well, in an ideal world, it depends on the fracture risk and the patient not having any secondary problems with it, and they want to continue, carry on lifelong if you have to. So, and again, it
And do
depends
you
on the
decrease the
choice.
frequency for a
No,
long time?
no, 6 months.
Yeah.
You see, denosumab's problems, it has problems, and I'm diverting from the script, but that's okay. The problems are that it started life in oncology,
Yeah.
right? And they give a lot of it, which is why we saw a lot of ONJs and AFFs in the oncology patient. But that is not to say it does not exist in the osteoporosis. We are increasingly a little bit less gung-ho and more cautious about our use of denosumab. There's been a paradigm shift in the use of denosumab, because historically we used to use it in patients with reduced renal function. So if you look at the guidelines, if it's GFR goes below 30, we don't give bisphosphonates, certainly not Zol, and denosumab has a little bit more leniency because it's not excreted by the kidneys. The problem is, as the renal function deteriorates, as it does when people get older and other comorbidities come in, it can sometimes cause severe recalcitrant hypocalcemia. We've had a couple of patients who ended up in ITU, and they had a long period before they got better. So once you have your fingers burned,
we need to do the
Okay.
general discussion.
We will, how much time do I have? I can figure it out. Can
No,
we 5 minutes?
we enjoy the discussion.
Panel discussion one.
ठीक है, तो shall we move on?
Either we can go directly on the question
No, no.
or you can go directly to the
But
panel
Kaushik sir,
discussion.
you were excellent.
Huh?
You were excellent and practical.
No, no. So I have lots of slides which I am show you, except maybe 3 slides.
Go ahead.
Okay. Shall I?
Next slide. Question 5.
So I'll be very brief. How much time? 5 minutes? Okay. I'll finish my 30
पहली
minutes
बात
off
तो
in
ये
5
है, we
minutes.
got to take this seriously.
Correct. So that is my key message. You have to. And because there are not enough endocrinologists or even rheumatologists who are there, and it goes back to a talk, in fact, Kaushik Das Gupta took me to Madurai, which has a very thriving orthopedics community. So I made the mistake of saying biologics should probably be only handled by rheumatologists. And I was pilloried by my orthopedic colleagues. वो तो ठीक है, but where are the rheumatologists? When patients come
Dr.
to
Jha is there.
no, but Dr. Jha is an exceptional orthopedic surgeon who understands rheumatology. But
For
anyway,
17 years now, orthopedic surgeons have been primed to rheumatology.
correct. And that is the way you have to adapt to what the reality is on the ground, right? Okay, there's no good saying. Anyway, so you've heard about CASIM, and it's just to reinforce the fact that we are going to get an older population, and even with the best will in the world, you will not have enough time and space to deal with all the fractures. So you do have a vested interest in preventing fractures, right? So that's the key message. It has a huge cost to the patient, to the healthcare system, and look at the responses you're getting from the patients. You know, this is not a good picture of our care, right? So I will leave this. Let's just, okay, no, there's not enough time. Dr. Chaturvedi will be very cross with me. So non-India is there. If you ever, if you go to France and say, drop down and go to India, try it. It might give you a little bit more confidence in some gray areas, and that's fine. Maybe if you invite me again, I'll have a bigger, more detailed discussion about practical things. What happens when you have a discrepancy between hip, which is fine, and lumbar spine, which isn't? How do you deal with it? BMD? Let me give you an example. Hip is minus 2.7, lumbar spine is minus 3.8.
Lack of
The
exercise.
lowest,
Lack of exercise.
Lowest BMD should be treated.
You could, or if you're using a fracture prediction tool, you make an adjustment of 10%, because you are only as weak as you're only as good as your weakest link. So if your fract is say 18% 10-year fracture risk, 3.5% hip fracture risk, you add another 10% to get the risk. So you compensate. There is a little bit of a fix here. You kind of hack, as they say in modern times. Yeah, you add a little bit, 10% per T-score, 1 T-score. So if it's two T-scores difference, you add 20%. Oh, sorry.
Kaushik sir,
Ji.
it's like in osteoporosis,
Yeah.
many situations, पहली वाली आगाज वाली ये बहुत अच्छी स्लाइड थी आपने जो डाली है
ये वाला?
नहीं वो जो उसमें
This one?
नहीं इसके आगे एक्चुअली मैं अपने बच्चों को समझाना चाहता हूँ इसके आगे in osteoporosis
जी.
many situations exist outside guidelines and require experience and more importantly sharing your experience. This is
I believe that.
actually the gist of this.
I believe that. Because, anyway, there's no time. Sanjay ji मुझे बता दें. Okay.
No, if everybody wants, I have nothing to do.
I don't want to outlive my welcome. कभी नहीं बुलाएंगे आप.
In fact, we are exhausting the panel discussion time.
बहुत बुरा बात. Anyway, so recency of fracture determines fracture risk. So there is a window. The next fracture will happen closer to the index fracture. So the time to intervene is when you have the index fracture. So refractures 50% in the years 0 to 2. ये याद रखना. So to stop or not, and that goes back to the primary question we discussed, is how long. So in order to try and prevent some of the long-term side effects, and they are incredibly rare, but if you run an osteoporosis clinic like I do, I've got a case series of 7 AFFs, some bilateral because my orthopedic colleagues would not preemptively name and play the other one, and we have to wait for the other one to fracture. And nowadays, I use that as an excuse. I say, why do you want her to fracture the other one? And then with the eye of faith, they could put us a hand, losers zone, anyway. But you are very familiar with what happens with the AFFs. And routinely, you should ask patients on anti-resorptives if they have thigh pain. We tend to overlook that. Mid-thigh pain is a precursor of some of these things. And if you have a lower threshold of doing an X-ray, you will find, and there's whole talk on it, like you're probably more experts than I ever will be. So the concept of drug pause is there, and the balancing the risks on benefits and conversations is again an art. It depends on how you approach it. There is so much misinformation about these drugs. People will come and say, "Mera sare, all my teeth will fall out." You know? And trying to convince them that we will probably have a 1/5 chance of dying if you have a hip fracture after a year. You don't want to put it in those terms, but these are difficult conversations. On the flip side, you will have slightly more middle class and relatively well-to-do patients say, "My sister in America has said I should go on to treatment. I've done a bone density scan." And you look at it and you go through all the process and you cannot convince yourself that that is right. And you get into this back and forth and they get very angry, they'll put it on play. You've all been there. So on the one hand, you have elderly, fragile patients who desperately need treatment, who will not have treatment. And on the other hand, you have what is called the worried well. And then again, that brings us to the art of medicine. How you manage these patients, how you manage their expectations. Writing a prescription for romosozumab for me is the easiest thing in the world. Convincing someone the fact that they have slight, well-controlled hypertension and that doesn't mean they'll end up with a heart attack is far more difficult.
What can be the precise drug holiday for bisphosphonates?
Usually 2 years. 2 years.
After how many years?
So 5 years of oral, 3 years of IV. Not necessarily 3 years, but 3 cycles also. Okay. So these are not my patients, but I have.
Yeah, this is very important. Have you ever seen this?
Oh yes. Oh yes.
I have not seen.
So I have 6 patients on AFF, and I have about 4 patients of OMJ. We published it as posters in our AFF meeting. I have. And I will show you pictures. I don't know if I have it here. Anyway, we move on. Dr. Chakraborty is getting increasingly angry with me. We have dealt with osteosarcopenia at length. I don't want to keep it, but do remember. So just remember this. They are in tandem. They are dancing what is called the tango, right? In close proximity with each other. I was
Dr. Das read it. Husband and wife.
Well, husband and wife are not necessarily always in close proximity, but yes.
They should be.
So, one exists, and this is the classical chicken and egg. Which comes first, which comes later, we don't quite know, but they do exist. The older your patients are, you must be conscious of this. And this is my last slide, you'll be pleased to know. So, awareness has increased, and the fact that you're here today is making us all a little bit more aware. There is this thing, we now bow at the altar of evidence-based medicine. When I started as a consultant 25 odd years ago, I did an evidence-based medicine course, and I used to do lectures and all the rest of it, odds ratio, hazard ratio, partly because there were big institutions in the UK where I worked, and they do a journal club, And some smart ass would say, oh, this is all rubbish because they didn't look at that, and then the confounding was that, and intent to treat. So I grasped the nettle and I tried to understand. But you know, after all that, you realize eminence, if you like, or experience. Ultimately, when it comes down to the single patient, I would like to ask someone who has seen, 25 such patients or 100 such patients, rather than going to a meta-analysis. And then sort of fag into my post-T session of my own NHS career, I think this is very important, and it's getting lost. We have fewer therapeutic modalities, but I think this is also a social problem. This is not just a medical problem. This is not orthopedic surgeons, rheumatologists, and endocrinologists talking about it. You need to mobilize public opinion, you need to mobilize the political process to take osteoporosis seriously. This is not a Western problem anymore. It is very much our problem. And on that note, I will exhort you to think of osteoporosis.
Thank you, Dr. Chaudhary, for a very practical and interactive session. Your emphasis on real-life decision-making, patient-centered treatment, and common myths in osteoporosis management is extremely useful for practicing orthopedic surgeons. मेरे ख्याल है पैनल डिस्कशन को कैंसिल करना है सर, तो उनको we need to message him also. Dr. Javed must be waiting for that. If we want to cancel the panel discussion, right?
Do we have time?
We shall now request Dr. S.S. Jha to present the IO guidelines on osteoporosis and sarcopenia in Indian orthopedic practice.
Last talk, it was an excellent talk, and we were talking about bisphosphonate. Historically speaking, bisphosphonate, when it was introduced, there was no forge mentioned that you have to break it after 3 or 5 years. It has been learned only out of experience. Can you give me my presentation? No, I will record it. Yes. So, many things, as was emphasized, we learn by experience.
I've seen a patient every time.
All of us are aware about the primary and secondary osteoporosis, and type 1 is the postmenopausal and type 2 is the senile or age-related. Well, all these I have talked about. We have to be conscious about the other levels where we say very severe osteoporosis and very severe low osteoporosis when T-score is -3 or below with multiple fragility fracture. Markedly low, -4 to -2.5, and severe low when it is -4 or more. Well, these are patients who are at very high risk patients. I will not go into the detail. Now, the IOA guidelines, what is the role of quantitative ultrasound screening? Because we quite often get it done in our clinic. It has a very limited role. Now, OSTA is one. When we screen our patient, it depends upon age minus, OSTA depends upon age minus body weight and is the preliminary screening tool. This is very important. You can do it in your clinic. So this goes by the name of Osteoporosis Self-Assessment Tool for Asian. OSTA is weight in kg minus age in years multiplied by 0.2. High risk -4 or less, intermediate -4 and -1, low risk is -1. these patients, high-risk patients, are advised to undergo DEXA along with the medium risk. So this COSTA we should remember. A patient with COPD more sees another screening tool, depends on a formula incorporating age, body weight and COPD. So we calculate it and we would further investigate this patient. Now what is most important, I will skip them. I have seen people having a lot of interest in therapeutics. So what is the definite indication for initiation of therapy for osteoporosis? And this is fragility fracture, as we have just now discussed. Now with a history of fragility fracture age-wise, what could be an additional indication for initiating therapy for osteoporosis? A person aged more than 50 years with a history of fragility fracture is also an indication for initiating therapy for osteoporosis. What evaluations? Very important question. When the patient is there, minimum investigation in serum level of calcium, vitamin D, renal and liver function test, para hormone as well. What are the recommended bone turnover markers for bone resorption and bone formation whose baseline level must be investigated before initiating therapy? P1 NP is for bone formation and for bone resorption it is beta CT. Now a female patient comes to us, so irrespective of age, which postmenopausal women are at risk of osteoporosis? Women with hysterectomy and or oophorectomy, irrespective of age, are at risk for osteoporosis. So if there is a female patient, this is curtain raiser 1. Now suppose she is Mrs. Madhumita, we have to ask her that irrespective of age, are you postmenopausal? Have you undergone hysterectomy and or oophorectomy? And the screening test FSH level must be estimated. Reduced ovarian function will have higher FSH level, but there could be other differential points like stress, medication, endocrine disorder, hormone replacement therapy and selective SERM therapy, which is an alternative to HRT. So when should they be considered in postmenopausal osteoporosis? Number 1, earlier menopausal period but not later than 10 years of menopause, and if available in India, it is not available, prefer transdermal DBT. What is contraindicated? When it is contraindicated, if there is migraine, active endometrial and active breast cancer and female hormone dependent cancer. Well, male osteoporosis more than 50 years with pre-existing risk factors, smoking, obesity and alcoholism must be assessed. So if the patient is a male, suppose he is Mr. Shyam Kishore, we have to ask them, are you more than 50 years with any of current smoking habit, obese, low body weight, because slender male less than 50 are likely to be osteoporotic or osteopenic, alcohol excess, more than 2 drinks per day, so there will be increased risk with excessive intake. And if there is a history of prior fracture as an adult, history of fracture in the family, in first relative, suspect, investigate, definitely if they are more than 70 years. Well friends, many a times we want to know if testosterone has a role. So testosterone replacement therapy can produce osteoporosis reversal. All men aged 65 years or hypogonadal men with symptoms of andropause and osteopenia, osteoporosis, evaluate serum testosterone level, both total and free. Total testosterone blood sample must be taken between 7 to 9 am. The contraindication is benign prostatic hypertrophic prostatic cancer, testosterone dose is 150 to 250 milligram every 3 to 4 weeks, but must be monitored and titrated during therapy. For pain related to severe osteoporosis, calcitonin could be given, but not more than 2 months. Bisphosphonates have aroused a lot of interest. What is the ideal indication? Friends, ideal indication for use is primary osteoporosis, including high turnover bone disease. And what is the definition of high turnover bone disease? That the patient will have high parathormone level and high alkaline phosphatase. If there is hypocalcemia, must be brought to normal, and eGFR must not be more than 30 ml before deciding to infuse. Bisphosphonate therapy is contraindicated for treatment of osteoporosis in chronic kidney disease patient with what level of eGFR. So the eGFR should be less than 35 ml. IV zoledronic acid 5 mg is safely repeated for how many years? And is 4 mg effective? IV zoledronic acid 4 mg or 5 mg can safely be repeated for up to 5 years, though classically it is recommended to be used only for 3 years, and 4 mg dose is cost effective. It reduces fracture risk in spine, non-spine, hip, and prevents recurrence of hip fracture. What are the main contraindications to avoid bisphosphonate? Avoid bisphosphonate in pregnancy, lactation, and recently done dental procedure. I will skip them. Talk of drug. After drug holiday following anti-resorptive therapy, treatment should be recommended after a gap of minimum 2 years. A drug holiday of 2 years following bisphosphonate may be recommended after 5 years of oral or 3 years of IV therapy, except in high-risk patient. Apart from drug holiday, any development of atypical subtrochanteric fracture, bisphosphonate may also be discontinued. In which situation? So this is important. Apart from drug holiday and development of atypical subtrochanteric fracture, bisphosphonate may be discontinued on achieving absence of osteoporotic fracture or absence of high fracture risk, or if the hip T-score is more than -2.5. Teriparatide, how long should be used? Continuously 2 years as of today. Do not prescribe use of teriparatide if the parathormone is above normal, there is unexplained hypercalcemia, there is elevated alkaline phosphatase, metastatic cancer is there. So these are contraindications, may be administered in adynamic osteoporosis patient with chronic kidney disease when eGFR is more than 30 ml per minute. Teriparatide has validated its potential as a potent anabolic intervention because it increases BMD, improves bone microarchitecture with reduction in vertebral and non-vertebral fracture, and can be safely used up to 2 years. But can it be extended beyond 2 years? Yes, if indications still exist. So you can go even beyond 2 years. Off-label use of teriparatide has been recommended by Indian Orthopedic Association guideline, and this is off-label use. And I must tell you, though we have recommended daily use, where the fracture union is the concern, even twice weekly it has been used successfully. So may not give daily. Denosumab, use of denosumab advocated for treatment of osteoporosis in chronic kidney disease patients across all stages of glomerular filtration rate, considering its relative safety profile. Combination therapy of teriparatide and denosumab is advocated in which stage of osteoporosis? This becomes very important. Combination therapy of teriparatide and denosumab advocated in severe and very severe. What may be preferential combination while a patient develops a fragility fracture during anabolic teriparatide treatment. While on treatment with denosumab, if a patient develops a fracture, anabolic teriparatide may be the preferential combination, and please provide a stick to the patient till the time teriparatide has taken over. I will come to romosozumab. We have lengthy discussion. May be safe in both sexes, but elderly female with severe osteoporosis T-score -3 are the preferred group, and Drug Controller General of India has recommended it. It has a dual mode of action and is currently not recommended to be used more than 1 year, 2 shots every month. Romosozumab is given once a month at 2 injection sites for 12 months. It is contraindicated in patients with cardiac events in the previous year. Romosozumab is not to be combined with or followed by teriparatide. Well, now I can switch over to the other presentation, please, which will deal little with osteosarcopenia. Friends, we must tell you, Indian Orthopedic Association is again working out guidelines. Right. Let me see this, please. Next.
Yes, sir.
So, talking about osteosarcopenia, we must say that it used to be the muscle mass when the first definition of sarcopenia came. But later on, it was taken out that no, it is not the muscle mass, it is the muscle strength and functionality of the muscle which becomes important. Right? I will skip this section and go to the management. Friends, there are limitations with pharmacological therapy. It takes time and the patient can easily get demotivated. So, sarcopenia, there has to be
Yeah, sir.
patient
Can I have the
compliance. Yes.
Can I have the pleasure of interrupting you?
Now, please.
Can muscle loss be treated by oral therapy? Muscle loss can only be treated by physical therapy.
Yes.
सार्कोपीनिया प्रो आ गया, कुछ भी आ गया, कौशिक है, मेरा दोस्त है, और सार्कोपीनिया, लेकिन एक मसल मास तो आपको
Yes and no. There are 3 elements minimum. Rehabilitation, you can say, or the resistance exercises are of course very important, but why not use something which can improve the muscle strength and the function as well. I am coming to that itself. So I don't say that it is not a multimodal management. So nutrition, muscle non-specific, which will include protein, vitamin, minerals, calcium, vitamin D, vitamin B12. But muscle specific, we have something which is CAHMB, and additionally carnosine, which is beta-alanine with L-histidine. So remember carnosine and leucine. So, so CAHMB is one important oral food supplement which can manage muscle weakness. It stimulates muscle for production, and through various mechanisms it enhances muscle growth and repair. L-carnosine similarly also reduces breakdown, and astaxanthin from genetic level stimulates synthesis of muscle fiber. So you can see the combined effect can give us better result. And what I would like to say that there is leucine on one aspect and CAHMB, which is derivative of leucine, on the other. Let us understand the difference. As we have anabolic when osteoporosis is there and anti-resorptive. So similarly, leucine is anabolic and CAHMB stops the breakdown of the muscle protein. And you have the dose is 3 grams per day. It should be given for minimum 3 months and preferably 9 months for showing the results. And if you give 3 grams, you have to eat 110 eggs per day, which you can't. So that is the reason it should be used. So a muscle-specific supplementation such as HMB, carnosine, astaxanthin is beneficial, improve muscle mass, strength, performance, endurance, recovery and mobility, reduces muscle pain and fatigue, and hence there will be reduction. Friends, there are 3 drugs. Bisphosphonate does not help muscles. Denosumab, it also can improve the muscle performance and appendicular lean mass in addition to decreased fracture risk. So denosumab is an attractive option. Well, teriparatide can also exert favorable effects on muscle regeneration and physical performance, and abaloparatide is a potential option in management of osteosarcopenia because of its anabolic skeletal effect, of course combined with limited muscle-specific data. And finally, romosozumab is particularly attractive option because it targets the WNT signaling pathway. It is relevant to both bone and muscle biology. So friends, in summary, if I can say, out of the 3 anabolic and anti-resorptive, teriparatide, denosumab and romosozumab can have dual effect on both bone and muscle. Thank you.
Thank you very much, Dr. Jha, for bringing the Ayurveda perspective and Indian practical approach to its important subjects. We will be skipping the AUSKS presentation as we are already late and we have completed the time. I'm sorry for that. We shall now begin the interactive panel discussion, preventing the next fracture and restoring function, and AUS case conference. I request Dr. Ashok Sahab to moderate this session, please. Welcome, Dr. Qasim. Dr. Kaushik, sir, you please come.
Dr. Dhawan, please.
Well, it has been an exhaustive session. Do we have any questions from the audience? Panel is ready.
Till the time that audience has questions. Well, I think one drug which has very extensively talked this evening is bisphosphonate, the anti-resorptive, or also the ribavirin. So, in an economically strapped country like India, do you think bisphosphonate should be out of the therapeutic regimen or it is still in?
Could you hear Dr. Qasim?
We are not able to hear.
Am I audible to you, Professor Qasim? No.
Yeah, I can hear it.
Can you hear us now?
Yes, that's much better. Thank you.
Okay. Dr. Jha has a question for you.
Well, I said bisphosphonate, is it in the regime for osteoporosis therapy or it is out? in an economically strapped country like India, do you think bisphosphonates are in or it should be out?
That depends on the value that keeping them out makes. So if you really need to compare the cost of generics and the cost of branded medications with the amount of savings you make to hospital systems, families, and wider society, it is clear that they have different effectiveness. So when you say economically strapped, and I look at those increases in people aged over 50, the bisphosphonates will miss so many patients who will refracture. You may be able to make the economic case that at scale, if you can introduce anabolics at a lower cost, that is far more advantageous. Simply because, Dr. Shah, you have so many adults who may be fracturing every year. And so I apologize for not being up to date on the current fracture data and its impact on India. But one could run some very straightforward simulations to see if the benefit outweighs the cost. But it's not a foregone conclusion anabolics are outside of economic grasp if the full impact is clear. And don't forget, the impact also includes lost productivity. So if grandma has a hip fracture or a pelvic fracture, the whole family has to stop working sometimes. And that's a cost we don't often see included in the UK, but there may be a very important cost for the economy of India. Does that answer your question?
Yeah, to some degree.
Right. Yes.
Anyone from the audience? Any question from the audience?
Dr. Dhawan.
Okay. Well, abaloparatide is not available in India. Abaloparatide is not available in India. Can you hear me now? Yes. Abaloparatide, no.
दूसरे माइक से बोलिए
Can you hear me now?
Yes, I can hear you now.
Okay, fine. I said abaloparatide is not available in India, while teriparatide is.
Yep.
Okay. So what we are deprived of between the two.
So the comparison then will be teriparatide and romosozumab, and what you're deprived of is a rapid reduction in non-vertebral fractures. And non-vertebral fractures account for 90% of the subsequent fractures after the first major fracture. That is, in the UK, with all its limitations of having scales of economy, that was enough for it to be recommended as the first anabolic first line. It would really depend on understanding the full impact of non-spine fractures on your population. And if that impact is high, that's what we do.
As Dr. Chan was asking, the relative merits of abaloparatide over teriparatide.
It's still unclear. It does seem to be a bit more hip and non-vertebral fracture, but the data is really driven by the BMP increases. You do get better bone density with abalo for hip than you do with teriparatide, but the fracture difference is not quite sure. The trial that they did for abalo wasn't as clear-cut as we think it was, because it didn't show any benefit for teriparatide, which should have worked. For some reason, teriparatide did not perform very well in the abaloparatide trial.
So, given that abaloparatide will not be coming off patent anytime soon, would you say that teriparatide is a good enough option for starting people on anabolic drugs? Because Romo is also 5
You broke
years
up
old.
a Can you say that again, Alfred?
So, given that neither abaloparatide nor romosozumab are going to be off patent anytime soon and be affordable, would you say that in order to lead with anabolic therapy for the high-risk patients, teriparatide is a good enough drug?
Yes.
That's a very firm answer, thank you. But it is a practical issue here, I think.
Yes,
Over and above, teriparatide, abaloparatide does not require.
why don't you call me on WhatsApp and I can do it that way?
Yes, in India, refrigeration is a problem. So with abaloparatide arriving here, it will facilitate, it does not require any refrigeration.
Can you hear me? Yeah, okay.
Right. One basic inquiry I want to know. We talk about osteoporosis, but we do not always speak about low turnover and high turnover bone disease. Do you think this should be highlighted?
The care gap you have in India is so large that the differences between high and low bone turnover in clinical practice have made no difference. So, for example, for the anti-resorbatives, there doesn't seem to be much benefit of using bone turnover markers to individualize treatment. And in patients for teriparatide, it's actually high turnover that has a better BMD response. And the big problem, Dr. Shah, with bone turnover markers are, they go up after fracture. So the very patients you want to stratify treatments in terms of which treatment to use, bone turnover markers, unless you can measure them within 24 to 48 hours, are of no use.
I am getting strong indications from Sanjay that it's time to close this session. I'll hand over to the chair for a few final minutes. Hang on.
Thanks, Professor Catherine, for your continued presence with us and trying to solve so many queries. But I think the take-home message has been given well, and with the available medication that we have in our armamentarium, I think we will leave this session in a better position. Thank you so much.
Felicity, you can't see us, but here we go.
I can see you.
Oh, you can? Oh, wonderful. There you go. Excellent.
And the President and Secretary are going to ready. Atul was Atul.
Virtual presentation.
This is virtual presentation I am accepting on your behalf.
अरे संजय उनको तो मत छिपाओ.
I'm very, very touched. You're very, very kind, and I regret not being there and having seen the Taj Mahal. Thank you so much, and have a really good session. And you're in good hands.
Thank you very much.
Bye, Cassie. Bye.
Hello.
खुद ही हो गया.
Hello. Yeah. Now, I would request now Dr. Salsa to felicitate Dr. Chaudhary.
Maybe I will be here.
आप भी आइए
Sir,
सर.
I please.
Be here. I will be beside you.
Please.
हमारी चिंता मत करो. बीच में है कहीं तो आप क्या?
अरे अरुण सर आप भी आ जाओ
अरे आओ आओ बड़े आओ.
सर सर सेल फोन
Wonderful interaction actually.
थोड़ा फास्ट फॉरवर्ड हो गया।
जो सीख सके तो सीख ले, ना सीखे तो नाड़ी है।
Thank you. Now I request Dr. Atul Koste's President, Dr. Ashok Saab, to felicitate Dr. S.S. Jha.
टीचर रहे हैं हमेशा, इंटरनेशनल सेशन के नेशनल
Okay. Thank you. Welcome.
Before the last word is being spoken, I would only like to tell you this story. I had gone to Calcutta to launch romosozumab, and the orthopedic surgeon who was chairing the session, he said, Dr. Jha, I completed 2 years of teriparatide and the same day I had fracture neck of the leg. Can you tell me why?
Why?
Yes, there is an answer to all the questions, and if you are genetically immune to responding to a particular so that is one hidden thing. So friends, now is the stage when we have to ponder upon why anti-osteoporosis therapy may not work. And this is not the only thing genetic. There are many things. Thank you very much.
सर मैं आपके
तो एक तो थैंक यू सो मच फॉर ब्लेसिंग अस।
It was like a homecoming.
मैं कौशिक ने जब आया तो मैंने कहा कि भाई तू सार्कोपेनिया और ऑस्टियोपोरोसिस के बारे में बात कर रहा है, तो
मैंने बोला उनको कि आपने रेफरेंस
है। मैं सोचता था झा साहब, ऐसे झा साहब मुझे प्यार करते हैं, मैं गलत हूँ, मैं बहुत गलत हूँ, ये कुछ ज़्यादा ही है। एंड ऑन द 1st of August मैं डॉक्टर S.S. झा ओरेशन दे रहा हूँ आयोरा ग्राउंड में, पूरी के अंदर। मैंने सर से कहा कि सर मुझे नहीं पता था कि आप इतना क्यों प्यार करते हैं मेरे को, बट फैक्ट ये है। तो मैंने उससे पूछा कि आपने मुझे क्यों सिलेक्ट किया? उन्होंने कहा आई हैव सीन यू थ्रू द इयर्स, तुम भी ठीक ठाक हो, एंड इट इज अ ह्यूज ऑनर फॉर मी टू बी प्रेजेंट इन द डॉक्टर S.S. झा ओरेशन at Ayora Common at Puri on the 1st of August.
That's a very prestigious conference now. And it has really gained its weight. Ayora has really picked up weight.
मैंने जब आपका रेफरेंस लिया सर, बोले अब मैं तुमको कौशिक मना कर सकता हूँ, बट अतुल को मैं मना नहीं कर पाऊंगा, ही इज माई फैमिली।
Thank you. Now you need to give vote of thanks as well.
नहीं सर कुछ बोल रहे
नहीं, मैं कह रहा था दिल वालों का शहर है आपका, और सब इतने अजीज लोग यहाँ हैं कि ना का तो कोई सवाल ही नहीं उठता था, एंड आई एम एट होम।
Thank you so much, sir. Thank you so much. We are more thankful that sir has taken the pain to come to Delhi to
मैडम ने क्या है कि नहीं, इट्स नॉट बिकॉज शी इज माय वाइफ, लेकिन जो झा साहब ने बोला कि ऑस्टियोपोरोसिस ऑस्टियोसार्कोपेनिया हम लोग वर्क करते हैं भाई, साइलेंटली वर्क करते हैं। आज तुम भी किताब ले आया हो, हम देखते हैं उसको, एनालाइज करते हैं, हाँ इससे बेहतर किताब हम लाएंगे सार्कोपेनिया पे, ऑस्टियोपोरोसिस पे ले आए।
राइट
तो मैं चैलेंज दे रहे हैं हम।
नहीं, ये वाला तो सर जेनेटिक सोसाइटी, हमें तो ऑर्थो सोसाइटी से चाहिए था।
कोशी के
नहीं वो अलग है।
अरे कौशिक, कोशी में मुझे थोड़ा सा अफसोस हुआ इसमें कि अपने जॉन इब्न और जो अपने लोग थे,
I wanted, actually this talk was initiated that I wanted a guideline on osteosarcopenia. I spoke to Dr. Naveen, and the very few people are all very close groups, so I can say 1.5 करोड़ रुपए मांगा। मैं सर अभी क्रेडल पे हूँ, 1.5 करोड़ रुपए में मैं गाइडलाइन नहीं ला सकता। तो मैं I just stepped out, but I want a guideline on osteosarcopenia. उसमें whatever way we can support, we can come forward. अगर मैं यहाँ पे ऐसा कर सकता हूँ, तो I can further come forward.
idea, and I think you can work with Orthopedic Society to conduct a study to create.
हाँ, कम से कम मेरे औकात के अंदर रहेगा, मैं जरूर। 1.5 crore is too high.
Thank you. Thank you.
Thank you to Dr. John.
On behalf of Agra Orthopedic Society, I extend my sincere thanks to Professor Qasim Javed for joining virtually from United Kingdom and delivering an excellent lecture on medical management of osteoporosis in fragility fracture. We are deeply grateful to Dr. Kaushik Chaudhary for personally visiting Agra and giving him a practical case-based and highly interactive session from the osteoporotic clinical experience. Now I request Dr. Atul Gulses to kindly close the meeting, please.
Thank you, faculty and members of the
जो लोग रहे हैं वो आज